My name is Judy Thomas. I've been in mental health for the last 2 decades. I currently work with young people, particularly. That's where my speciality is, but I have worked across all the age groups. I wanted to initially become a psychologist, but it was so hard to get in. And I applied like over a 3-year period, and I thought, I can't wait anymore. So I looked at what was nearer to it in terms of the way you work, and I felt nursing sort of fitted that much more. So hence, that's how I got into mental health nursing, and I've just stayed with it since.
What do you think are the biggest challenges in minority mental health? And obviously for you being sort of on the ground working as a mental health nurse, what was your sort of take and experience during this time?
I think it's always been on the agenda in mental health about how do we support people from ethnic minorities much more accessing our services, and how do we retain them, and how do we work and think about them culturally in terms of their cultural needs, the language and how they communicate, and what does that mean. One of the services I remember working in was a rehabilitation unit, and it wasn't a rehabilitation in terms of helping someone to rehabilitate from mental health. It was actually many ethnic minorities were given wrong diagnosis in an earlier age, and they were trying to rehabilitate them to let them know they were no longer, for example, schizophrenia. It was psychotic depression, or it was depression. And that was quite interesting. And one of the key things was because the way we as ethnic minorities express our emotions, it may be different to the way other or more European people express it. In particular, for example, if someone's distressed and actually having depression, what you'll find, a lot of men, I think what I find with a lot of men, particularly ethnic minority men, you may get the more agitation, irritability. They may not use so much words. You may get much more irritability. And they may talk about more cultural belief things in that you're not picking up the depression, you're picking up aggression and agitation. You then focus on that, but also you start thinking, okay, particularly if you're coming from a background where you don't understand where those beliefs come from, which may be beliefs centered in the culture, not necessarily in the head of that person, that you may start thinking that person's psychotic. But really, they're distressed, they've been depressed for some time, they've not been able to communicate, but it's got to them. And that was what was a lot of the themes during those times. There's always been ethnic minorities working in mental health. Didn't always have a voice years ago. Say was that you often find people that were at the top were much more European. So hence the meetings that would cast or give create a platform for you to have a voice about what was going on for a young person. You weren't always on that platform. It's different now. Of someone who I think was a Bangladeshi background and a young female talking that was sharing things that the clinician that was working with them didn't understand and perceived that it wasn't traumatic because they weren't emotional enough. And I remember saying, okay, from the information that was provided, I was able to say, no, they are going through trauma. The difference is that in a lot of ethnic minority groups, particularly if you're coming from overseas, if you've suffered trauma after trauma after trauma, you to cope, a part of that coping is to detach emotionally from the experience that you're having. They just cope because they can't change it, so they don't get emotionally. They don't allow their emotions to be involved, because if you allow your emotions to be involved, you won't cope. You will want to die. You may probably want to kill yourself, in the way that you get a lot of more young people being able to feel that they can have those experiences in a Western world where there's set a framework, a support system that can cope with it, whereas in those places there isn't. So I was sort of framing it in that way to help people to understand that this is probably what's been happening with her. So basically, before you can even touch on the trauma, you may have to develop a relationship with that person for them to feel safe enough and feel that they could be held enough to be able to be open and express. And you may even have to teach them how they can express themselves emotionally, because they've not probably
come in for so long as well. It's like they don't know.
Exactly. And I think why I mention that is because it's so key, because you'll find often sometimes it's those things that could actually even prevent someone from being able to access the services that they need. Because often the way the service works is that you should be able to, when you see someone, they should open up, say everything or say enough for you to say, okay, that we will continue seeing them. So because of the stigma attached to mental health, there's already stigma attached to ethnic minorities and already, and mentioning the Black Lives Matter, so much has come out of that, isn't it? People reporting and expressing their own experience from all different ethnic backgrounds about what they've gone through and what they've experienced or what their families experienced that they've not talked about before so openly, but somehow the Black Lives Matter enabled them to talk about that. And then if you're having to constantly worry about stigmas that's attached to your culture, your race, the last thing you want to another stigma is this mental health stigma. So you may not take up those inputs. You may not even allow yourself to be seen. Actually, you may have family, and that's common. You get families who would want to shut that down very quickly, and there's nothing wrong with them, particularly if they can manage it. But then the problem is that they manage it until they can't, and often what you get is young people or even adults that by the time they are taken up, they do access treatment, you may get them accessing it under a section. Hence why you hear sometimes that there's more ethnic minorities who are sectioned than there are in the European white community.
And it's just because of that build-up, essentially, they kind of swept under the rug for so long.
Yes. And then you're not actually doing therapy. You're actually doing crisis management, trying to get them well again, because you need to before even therapy can even be considered.
To rehabilitation as well, and what you were saying before. So when you saw those sort of minorities who are now in rehabilitation care because of misdiagnosis for mental health, was that also a consequence of having the wrong medication and treatment?
You're being treated for something you've never had and then having to be rehabilitated, and some of them were scared, so they'll actually make themselves unwell to stay in the system because they've been. You don't forget, your work is constantly telling people you've got this illness, you need treatment. So if you're working with that constantly and convincing someone
mentally
and then,
as well,
you end up believing it eventually. So you then have to re-educate them. You have to convince them they don't have that. You're no longer psychotic. You know that this is because they're not going to be convinced. They get scared.
Yeah. So the sort of rehabilitation care, is it more just a sort of behavioural therapy than trying to sort of talk them? Yes,
and working through some of those anxieties, and that can sometimes take just as long as their general treatment for whatever they've got at that point, really. We've had quite a few ethnic minorities actually going into hospital under section because of the anxiety around the fear of getting COVID, or what you get is that they've had a family member with it. And obviously, as you know, that they've sort of indicated that ethnic minorities are much more vulnerable, although we know it's because there are more ethnic minorities working in the health services. Yeah. And the initial anxiety around having the lockdown that they've not coped with, and then getting used to it to the point where they feel safer, having to then go back out, has created a lot of anxiety and unwellness, as actually depression. We've had a lot of that, dealing with depression and anxiety, suicidal ideation. You've got a lot of young adults whose not sure about what the prospect of university, college or work is for them, and you're getting a lot of depression there because they can't see a future. But you've also got the pressure within the family, because you've got a family member that may not have work anymore, may not have a job anymore. So the financial pressure on the family as a whole, that's caused a lot of mental health struggles, particularly anxiety and worries, and hence you hear about the rise in domestic disputes as a result of that, or a number of other things. I think the struggle that we've been experiencing is that obviously some of us have had days where we're working from home to create the space that we are so able to social distance, because obviously the room is not, and patients are being tested as soon as they come into hospital to see if they have COVID. So they may have to self-isolate in a room for a while, which causes even that much more stress and anxiety, and often, where there may have been much more physical contact, reassurance you're not able to do that anymore. And obviously you've got staff who, you're there to support patients, but then you're constantly worried also about whether you're going to get it or not. So sometimes I remember when COVID first hit in, so many nurses were anxious and worried because it was very new. We were still trying to learn about it, and you spend a lot of time cleaning everywhere as well, and patients are finding that a struggle because they're having to do it through Zoom. So hence there's lots of anxiety, agitation, irritability around that, which particularly for nurses are having to hold as a result.
Also, so we sort of had quite a lot of submissions discussing sort of the lack of representation in therapy. So after they sort of overcome that barrier of access, they feel sort of alienated, and it's very hard for them to open up because there's that lack of representation. And one person even detailed sort of the struggles of attempting to seek mental health care in the UK, where he ended up being bounced from sort of group to group to group, which ended up further deteriorating his mental health.
There is a lack of representation. A Muslim or who doesn't want to be a Muslim anymore, but they also don't want anyone talking badly about or perceiving that faith as in a negative way, and that becomes on their mind, because they know that that there's negative media around being a Muslim.
Those assumptions and stereotypes that people already have. Yeah,
exactly. So they won't open up. And they won't open up unless they felt it was someone who could understand that background and who relate, that will enable them to open up. So they end up going through probably therapy without being understood, and then that therapeutic relationship breaks down, because obviously the services, they tend to have a time frame about how much therapy input they can provide, or what you get, the therapist picking up already that this person's not that engaged, I'm not sure if we can work with them anymore, and refer them on. And then they get constantly referred on because no one's picked up on why that person's not engaged. So they can get passed on in that way.